Well, Dr. Soto, thank you very much for taking time today to educate your patients and their loved ones about some of the conditions that they all have to face every day. Before we go into talking a little bit about pelvic congestion, pelvic pain, tell us, you as one of the experts in the field, how did you first get interested in this field?
That's an interesting story. I had cramping in my legs every night between 3 and 3:30. I was a gynecologist, obstetrician, and so whether I was on call or not, I was up every night walking off leg cramps. About 12 years of that, and I happened to run into somebody at a meeting who said, "Oh, you might have venous insufficiency." I talked to doctors in the doctor's lounge, my friends. I was 60 pounds lighter. I worked out, couldn't figure out what was going on. This vascular doc, he fixed my left leg on Monday, my right leg on a Wednesday, and I never had another leg cramp. And I thought it was impossible that nobody knew anything about venous insufficiency and the symptoms thereof. And once I saw how it worked, and I saw patients every day in my clinic with varicosities and swelling and cramping, I learned so much from him that it just happened to be fate that someone from Center for Vein Restoration was in my clinic. It was one of the liaisons and said, "Oh my gosh, this is what we do, and you'd be great. You do ultrasound." And I then met Ken Nguyen, I met you, and I was convinced that this was actually a real field of medicine that was underrepresented. And not many women were doing it at the time. So based on what my experience was personally and the fact that I felt I could probably help a lot of women, turns out a lot of men as well, it just made sense to me that I needed to be in this and making this more of a known field.
Well, thank you for that. Thank you very much. So for an average, say, a mother of three out there with pelvic pain, with lower abdominal pain in the pelvis, tell us how your thinking has evolved, first as an OBGYN. What were the common causes at that time? What could you treat? What were your frustrations? And where is your thought process today?
The change in how I think about chronic pelvic pain, it's unfortunate that it's happened so far after the fact for me. Previously, chronic pelvic pain, once you get to 6 months or more of pain, you've thought about reproductive age problems, pelvic inflammatory disease, just general dysmenorrhea, endometriosis, and any GI or GU issues like interstitial cystitis or IBS. You go through all the different systems. You try birth control pills, you try GnRH agonists, you do ultrasounds, you do CT scans, laparoscopy. Once you've gone through the hormones and the trials and the kids, we were kind of at a loss if we didn't find anything else at that point, because if we couldn't find anything organic with the bowel, the bladder, the hips, the pelvic bones, the musculature in the pelvis, it was pain management. Most women held out for a hysterectomy, hoping that that was the root source of their symptoms. And to fix or cure somebody with chronic pelvic pain was pretty rare. There were some who responded to hysterectomy eventually, but I find that not knowing all that time that there is a real disease of pelvic venous origin was really unfortunate, because there are a lot of people that I could have helped then. So well before getting into the hysterectomy now, I would say it's an ultrasound scan to look at the pelvic vasculature, whether there's iliac vein compression, pelvic varices, reflux in the ovarian vein. I've actually had friends of mine who see that I do this now, and they're asking me who to send their patients to and what to look for and how to approach it. So this would make a big difference in the management of chronic pelvic pain for a lot of people.
You said an interesting thing, what to look for. So for a patient out there who may have lower abdominal pain, what are the typical symptoms they should be looking for before they reach out to an expert like yourself?
So just a general sense of heaviness, aching, pressure, a constant feeling like there's just something there and it's uncomfortable. It can be worse on a cycle, but it's not simply cyclic. It's more days than not. And if it's a gnawing, aching, just a pain that you almost can't describe without, feeling it or trying to compare it to, the worst kind of stomach upset. It's a hard thing to put your finger on, but it's a chronic achy pressure pain that is typically better, if not completely resolved, with lying down. So if you lie down when you have this kind of pain and you put your feet up and you get moments of relief, or you can sleep the night because your symptoms are better, I think that's pretty telltale that it's something more than just a uterine or a GYN issue.
So Dr. Soto, you are not an interventionalist in this particular field itself. You're more of a diagnostician, and then you send your patients for treatment. Once they come back to you, what has your experience been like?
Patients are so grateful that there is somebody who has another potential option for them. So simply going to, Center for Vascular Medicine, to have the ultrasound to look for another option gives people hope. It's an optimistic opportunity for them that they haven't had in their whole GYN workup. And once they get a diagnosis, even on the ultrasound that says it looks like this is probably your problem, they come back and they're happy and excited at the thought that there's a possibility for treatment. When they go to Center for Vascular Medicine for the actual venogram, intravenous ultrasound, and or stenting, they come back and they feel like they have been treated like nobody else. The staff is caring. They're really complete with explanations on what's going to happen, what they can expect, how they're going to feel during recovery. And they come back to me and they're a little achy during recovery as promised. But I can tell you, like, the first week to two that I see people after these procedures, they say it's kind of like taking your foot off of a garden hose. A lot of that pressure just goes away and their legs feel better, their lower pelvis feels better. May not be completely resolved, but I see people 3 months out, 6 months out, and they're excited. They're not taking pain medication anymore. They're up and running around with those 3 kids that they have at home. So they really do feel better after these. And the type of care that they get in your centers, with people being so caring and they just feel like they've had excellent care and really incredibly caring people taking care of them.
And what do you expect from them so that they can continue to be compliant and be taking care of themselves? I'm sure other than just regular things where they've got to continue to exercise, come back for follow-ups, is there anything more specific you ask them to do so that their treatments can be more durable?
Well, I ask them to wear compression stockings if they're standing or sitting for long periods of time, just to support circulation and give them better feeling in their legs and even their pelvis with that. But maximizing your body weight, being physically active, cardiovascular health is really important. The more you move and the more you take care of yourself, you don't have to be skinny, I tell everybody, but if you can be in good physical shape, you generally feel better as a person. But I think knowing what you feel, if something recurs or something returns, come back earlier. If you're feeling, some of the symptoms return or a different symptom, or you're starting to see some unusual varicosities, don't ignore it and make sure that you come in to be seen sooner rather than later. Overall, I think it's general awareness on how you feel.
Well, Dr. Soto, thank you very much for your time. We know you've got a busy day ahead of yourself, so thank you for taking the time for this.
Okay, I appreciate it. Thank you for the opportunity.